Scrolling. And I found it.
Okay, so again, some of this stuff we've already talked about, some stuff we still need to talk about though. Some of the things are just going to be, positioning tips and hints and things to help you to be able to visualize what you need to see. So that the AP, internal, external rotation, the neutral rotation, we're really not going to talk about. We'll talk about the axillary. We'll talk a little bit about the Gracie. The outlet is just a, it's a Y view with a caudal angulation. We'll talk about the clavicle, AC joints, and AP scapula to finish out the scapula itself. So same things that we talked about before. Positional pain, should the patient upright if they come to you upright. Kyphotic patients kind of provide you a little bit of a imaging challenge, especially in the scapula, trying to get the central ray perpendicular to the scapula. So we'll take a look at that. So the shoulder, the bones of the shoulder, of course, you've got the scapula itself, you've got the clavicle, you've got articulation at the AC joint, you've got the articulation at the glenoid fossa between the head of the humerus and the scapula. So again, the AP, the only thing that I want to point out here is that your central ray needs to be 1 inch inferior to the coracoid process. And how you find the coracoid process is that it's pretty much where that soft tissue indentation in your shoulder is going to be, right? So where you see the deltoid kind of come in and make a turn, and you see the pec come in and kind of make a turn, that's where your coracoid process is going to be. So just kind of coming through all that. We've got a little bit of body rotation in this case. You can tell because the clavicle is overlapping the spine. But also look at the scapula. The scapula should be underneath the ribs a little bit more than what it is. So if this was shot AP, it's shot AP with the right side elevated away from the image receptor. And this would be rotated towards the image receptor. This is almost a Gracie method. So again, looking at the spine, looking at the clavicle, you can see that they've got some rotation. In this case, is towards the image receptor. I'm not sure that we don't have something going on with that scapula right there. Can you kind of see that dark shadow right here? Maybe if I turn some of these lights off, you can see a little bit better. Technology. Okay. Let's see.
I think you just need
This
a light
is great.
switch.
Yeah, the more I push this, the brighter it gets in here. It should turn them off eventually. Push all those and see what happens. Yeah, that's as good as it's going to get. But anyway, there's a shadow right through here that maybe the patient's anatomy and maybe that we've got some sort of issue with glenoid fossa. Okay. So again, if you have a patient who's a little bit kyphotic or if they're slouching because they have a shoulder issue, again, the patient's going to have some pain if they've got some shoulder issues. What you're going to see if the patient is kyphotic is that you can see the superior angle of the scapula. That's what you're seeing right here. And that's going to be projected above the clavicle. That should be, the top of the scapula should be pretty close to where the clavicle comes across the patient's body. So normal as opposed to kyphotic, you can see the difference between the two. This is not the same patient. This is an older patient, probably with some compression fractures as opposed to a healthy patient. But you can see what kyphosis looks like on a clavicle or a scapula or anything like that, a shoulder. You see that superior angle projected above the clavicle. As opposed to a lordotic, now your clavicle is starting to look a little bit like a epiaxial, but the superior angle of the scapula is a little bit below the clavicle there. So internal rotation, no, that's external rotation. We've got the greater tubercle, neutral, external. That would be internal rotation. What you get with the internal rotation is not just the lesser tubercle projected medially, but you also get what looks like more superimposition on the glenoid fossa. So the inferior superior axial projection is what we're in a lot of cases refer to as the axillary, and the dangers here, not dangers, but the mispositioning, most common mispositions that I see or saw were one of two things. One was overangulation, and with overangulation you may project the head of the humerus off the image receptor. And the other gives you the same thing, and that is your positioning. You know, the x-ray beam shooting from the floor here, but the other thing is that the technologist would not have the patient bend their neck over, and when you bend the neck in the opposite direction of the anatomy that we're trying to get an image of, then you're limited by how far the image receptor can go in. But just look at how much more that buys if I just bend my neck over a little bit, right? So a very important step that we have a tendency to overlook. If the patient's laying flat on their back, then you can put the patient to work. Some of your positioning textbooks, they're real meticulous in how you're supposed to position this. All right, so I'm laying flat on my back. I get my arm extended in a natural lay. If I'm laying on my back, what's the position of my hand? Supinated, right? Well, they'll point that out, but it's pretty common sense. I mean, if the patient has some sort of shoulder issue, is that happening? No, it's not, right? So just understand that's what they're talking about. So what you can do then is have the patient hold the image receptor, and you've not done really significantly anything, and just having the patient bend their arm. Now, the degree of your angulation is going to be dependent on how far the patient can abduct their shoulder. So if the patient can only pull their shoulder, about that far, then your angulation may be more like about 20 degrees, as opposed to if they can come out, it's going to be more like 30 degrees. So turn the head, bend the neck, and adjust your angulation according to the patient's level of abduction. Best case scenario, we want the abduction all the way out to 90 degrees. Your central ray, the degree of angulation is going to be dependent on that, how much abduction you have. So what it should look like then is what we've got here is we've got the glenohumeral joint space. That's glenoid fossa. And you notice that the coracoid process looks like it's attached to it, right? It's not, but it looks like it kind of is. So if your angulation is right, then what you should have is pretty close to open glenohumeral joint space, and you should have it looking like your glenoid fossa gives rise to your coracoid process. Okay? So then what happens is if those two don't look like they're superimposed, or not superimposed, but one's coming out of the other, then what's going to happen is with the increased angulation, you're going to project the coracoid process away from it. Under angulation, it's going to look like it's coming out of the top of the glenoid fossa. Coracoid process is going to look like it's coming out of the top of the glenoid fossa instead of out of the side of it. Okay? So if we have too much angulation, again, you can see the glenoid fossa is projected medially. Not enough angulation, we've got separation between the two. Okay. So surgical shoulder injuries, our fractures, in a lot of cases are going to be in surgical neck, and they're going to be impacted fractures. We can have some avulsion fractures as well. Dislocation is probably most common, with the impacted fractures probably being the second most common, or very well may be the opposite of that. So AC joint separation and dislocation are not the same thing. So if you're a sports fan, your favorite football player gets a separated shoulder, that's something totally different. What that is AC joint separation, and we'll take a look at that here in a second. Broken clavicle, very common in kids. And then broken scapula is pretty rare, but it does happen. So impacted fracture, that's what we've got here. In most cases, and again in my experience, the demographics here are older patients, osteoporotic, and most of the time they're just going to sling the patient. Most of the time they're not going to do any kind of surgery on the patient. Now, I've seen surgery, like it's kind of like a hip pinning, except for the shoulder. So I have seen it, but in most cases, what I've seen is just having them sling it. All right, so surgical neck fractures. We've got the surgical neck, we've got the humerus, and then we've got the head way over here. I don't know how they got this patient into this position. I think that I would have refused if I'd have seen both of these first. But they got axillary on this patient with a humeral head completely displaced with a pretty nasty fracture. So anterior dislocations, again, tend to be inferior. A lot of cases are going to be a little bit medial, like what you're seeing here. This is a little less medial, but it's still there. Greater tubercle avulsion fracture. I don't know that I've ever seen that in my clinical practice. Arthritis, patient probably looking at a total shoulder replacement there. So again, AC joint separation and a separated, that is a separated shoulder as opposed to a dislocated shoulder. So the AC joint is just a fibrous joint, and it moves a little bit, but nothing like a synovial joint. So those ligaments can be ruptured partly or entirely. We had a student go through the program one year, and I may have mentioned this before, but he had a type 3 AC joint separation. And I was already on campus. I think he was at Mother Francis anyway, and I was clinical instructor at ETMC. So I never had first-hand knowledge of this, but several of the students said that they would see him pick up like a portable grid or a gridded cassette. A gridded cassette probably weighs 10 pounds or so. We've got one in the lab. So they're kind of heavy, right? They said that you could see, pull his shoulder down and his clavicle would just be sticking out, right? So it's pretty bad, but he made it all the way through school. I assume he's had it repaired since then. But how we see AC joint separations is just that, and that is to have 2 images done. Most of the time, you're going to do both bilateral, upright. The patient's going to be upright, and you're going to do with and without weights. So upright, have the patient hold on to something to exaggerate that gap, right? And then they can diagnose what level of separation it is. So total disarticulation is type 3. Clavicle's just flapping in the wind, as opposed to type 1 is very subtle, and that's the reason we do bilateral, is to catch that. The problem with AC joints is that we have a tendency to, if we're not doing chest x-ray or lateral C-spine, what's our SID? 40, right? But anytime you shoot a chest x-ray on a patient, let's say they're a patient that's, it's a portable chest x-ray, you do an AP and they're supine and you can't get 72 inches, where are those shoulders? They kind of, because of the divergence of the central ray, it kind of projects them way out to the periphery, right?
So let's say you've got they still make image receptors that are 14 by 17, okay? So even the digital image receptor is 14 by 17. And if you're looking for AC joint separation, divergence of the central ray at 40 inches is going to be so great that it might project the AC joints off of the image receptor. What you might want to do is back up to 72. That's my stomach. Back up to 72, you're using more of the middle of the central ray. Did y'all hear that? What's for lunch? So back up 72 inches, you're going to have less divergence of the central ray, more likely to get all that on the image receptor. Okay, so upright, with and without weights. Take this with you to the registry. The textbooks recommend that you not have the patient hold weights, but you attach the weights to the wrist. Because if I hand you something and you grab it, what's your first reaction? If it's something heavy, kind of pull against it, right? You pick up your backpack, and what do you do with that shoulder? You kind of shrug. So I don't know that the patient wouldn't do that anyway if you put something around their wrist, but the theory is that they're less likely to. So now ask me how many hospitals I've ever worked in that had something that you could attach to the wrist for AC joints. Exactly 0. Yeah, so you've just got to tell your patients to relax their shoulders, not pull against. Stomach's still going ahead. Okay, so AC joint separation, you see any problems with this image? Collimation. Yeah, I'm gonna ride it, you know, I get that the trend now is less collimation, open your collimators. This is a hill I'm willing to die on. This entire collimated field shouldn't be any more than about that right there. This is just awful. It's a young patient too. So AC joint separation on wide view, you can see that as well. It's probably not as diagnostic as with and without weights. Broken clavicle. They do pin clavicles, not as often as, probably more often than what they used to, but not as often as some of the other broken bones. So this patient has not only a broken clavicle, but also a broken scapula. So I don't know if you've ever had any shoulder pain, especially shoulder pain in the upper back. I've never broken my scapula, but I have torn the muscle that goes right up under the scapula. Still flares up now and again. If you ever see me walking around, I don't turn my head very much. I'm having an issue with it. So that's with a torn muscle. I can't imagine this thing is, pretty messed up. I can't imagine how much positional pain this patient's going to be in. So again, you might want to take a look at this patient before you lay him down or stand him up, especially before you lay him down on that. Positional pain is just terrible with shoulder injuries. So the Gracie method, I put true AP in here because I've heard it referred to as true AP, and it's not. That's why it's in the quotations. So if you just hear it referred to as true AP, okay, whatever. Just let people have their day, right? But what our purpose is in getting the Gracie method is to oblique the patient enough so that we can see through the glenohumeral joint space here. Go back this way. Here, okay? So in an AP, we've got that superimposition, you just can't see it. So what we're going to do is oblique the patient about 45 degrees towards the side of interest so that we can see in between the head of the humerus and the glenoid cavity. Okay. Some hospitals, I hear, use that as their AP, so they would externally rotate, use that as AP. So your degree of obliquity is going to be 35 to 45 degrees. The purpose is to try to put the scapula parallel to the image receptor. And you would have
a tendency to think, well, okay, if the scapula is parallel to the image receptor, then that's what we would use for an AP of the scapula. The problem with that is that as you oblique the patient towards the side of interest, the scapula tucks up under the ribs. So that's not what we're gonna do for an AP of the scapula. Even though that's the point, is to try to put the scapula parallel to the image receptor. And that's what we should see is the open glenohumeral joint space, right like that. We've got the corcoid process in the way, but that's okay. If we have over-rotation, then what we're gonna have is a greatly foreshortened clavicle. The glenohumeral joint space closes, right? So it's not open anymore. The patient is too lateral. Okay, we kind of did the Y view to death. So what we want to see is we want to see the vertebral and axillary borders on top of each other. If the vertebral borders over the ribs, and that would indicate that the patient is too AP or PA. And if the axillary border, which is that fat, puffy portion, is over the ribs, then the patient's too lateral. Okay, so AP of the clavicle. We've got AP and our AP axial. All right, so because again, what we're looking for is anatomy, small anatomy. It's probably a worse situation than what we had even with the humerus. We've got small anatomy. We're trying to put it on a larger radiation detector, right? So if you focus directly on the clavicle itself and you leave your collimation wide open like that, you're going to get a lot of direct exposure to your radiation detector, and it's going to cut off way too soon. Okay, so collimation is absolutely vital for a AP of the clavicle. So collimate and go ahead and hit it with like a +1 or a +2 density in order to get adequate exposure. All right, so if the patient's kyphotic, you're going to want to get the patient upright if at all possible. Even though I've never seen anybody shoot PA clavicles, it would reduce OID. So if you see that on a registry, that's what it's referring to. So AP of the clavicle, we want to evaluate for rotation by looking at the medial end and where it looks like it comes in contact with the spine. We're going to have the medial end somewhere around T3, T4. Just a good clavicle. Sorry, y'all. And should have had a bigger breakfast, I guess. So for the axial, we're going to increase we're going to angle 15, 30 degrees cephalic. And where we had that imaging problem with the AP in the photocell, it even gets worse with the axial. Okay, so what I really recommend that you do is if you phototime your AP, then notice what your mass readout was, turn off your phototimer, set your technique for the axial, and just use the same technique. You're not going to be shooting through really any more tissue, so you don't need to increase anything. You can use the AP technique for the AP axial and not have those problems with phototiming. All right, so most fractures occur on the lateral 2/3. Some of the fracture is going to be medial, but most of the time it's going to be from this point here outward. And even with the AP axial, we're going to have some medial rib superimposition. If you angle enough to get the clavicle completely off of the ribs, it's just an ugly image. You're going to have some sort of superimposition on the medial end. So good collimation. Make sure you include everything that needs to be included. That's what it should look like. Again, we've still got some superimposition on the medial end. That's okay because most of your fractures are going to be the lateral 2/3. All right. So clavicle fractures, they say that the danger of clavicle fractures is that one of the fragments could potentially puncture a lung, kind of like ribs. Never seen that happen, but, theoretically it could. So, this, I do know the history on this one. The guy, he was, it was a motorcycle accident, but it was a slow moving motorcycle accident, and he kind of fell over and broke his clavicle. And they wanted to pin this, and he just would not allow it, so they manipulated it and manipulated it and manipulated it until they got it, where it's acceptable. So again, just more clavicle fractures. Okay, any questions?